So she's starting the live stream. We're trying to see whether it's working. Nice to see you there, Madeline.
Yeah, no,
Looking forward to Ettang and to hear what you have to say about advances in the rural healthcare. Yeah.
it looks like the live stream, although we're not going to really need the live stream tonight. So, Steph, I think we can start.
Okay. Okay. Well, I'd like to introduce Dr. Enwongo Ettang. He's a specialist family physician working in the Pietermaritzburg area of KwaZulu Natal. He's got a special interest in diabetes, child health, men's health, female health, chronic disease management, and geriatrics, and has more than 14 years experience in the medical field. And I also see he's quite active on all the social media. If you have a look, he's got lots of posts and things on Instagram and Facebook about the services he offers. Okay, then interestingly, he is the chair of WONCA Young Doctors Movement for Africa. And for those of you that don't know about WONCA, this is the World Organization for Family Doctors, and they aim to encourage and develop high standards of care in general practice and family medicine. They are also running in a partnership conference in Cape Town in September, the Ubuntu 2024. So if anybody is interested in that, I will post on the chat. But welcome, Dr. Ettang. We're looking forward to hearing what you have to tell us.
Thank you so much for that lovely introduction. Good evening, everyone, for those who are live and for those who might be watching the replay. I hope you're all well and comfortable. I just want to thank you for joining us today. Before I go ahead, I want to just extend my gratitude to RuDASA for giving me this opportunity to share insight on a topic that is kind of close to my heart, which is advances in rural healthcare delivery. As she rightly said, I'm Dr. Enwongo Ettang. I was born in Jos, Nigeria, which is in the middle belt of Nigeria. Did my undergrad in Nigeria, and after my internship, I moved down and did my internship again here in South Africa. I've worked across two provinces, which is KwaZulu Natal, Eastern Cape, and then back to KwaZulu Natal again. As she said, yes, I finished my exams 2 years ago. I had the opportunity to do my graduation, of which Madeline Miller was there, which I've added that picture at my graduation as a family physician. But I'm based in Richmond, KwaZulu Natal, and my jobs includes being a telehealth provider, which I provide services online. I work as an emergency room physician at Mediclinic and Midlands Hospital here in Pietermaritzburg. I also work, I cover a clinic as an NHI doctor, working in one of the rural clinics here, and also run my personal practice here in Richmond. I've been married to my wife, Dr Ettang, who's for over 15 years. We have two amazing children who are pretending to be shy, watching us do something there. I have a small dog, Jet. And when I'm not working as a doctor, yes, I do play my music, my local church. I love traveling. I love reading. But I'm not just a doctor. I'm also involved in also some philanthropic work around. But you're not here to listen about me. So for the next few minutes, I'll be talking about current challenges in rural health, technology advances, innovative healthcare delivery models, policy and funding. I'll pick a few case studies and I'll leave it time for us to ask or answer questions at the end. But the goal is probably to highlight the importance of advancing rural healthcare and also to share some practical strategies and lessons I've learned from various regions together. All right. So one of the major challenges has always been, which is probably a recurring conversation, has been about accessibility and infrastructure. And one of the most significant challenges that we face in rural healthcare is about the limited access to healthcare facilities, or limited access even in healthcare facilities. One of the days I was working in a rural clinic where we had a patient who had just changed condition, and we ended up intubating that patient. Now, it took about 6 hours for the ambulance to come and pick that patient. So imagine nurses taking turns to ambu bag this patient, because as at a rural clinic, you do not have a ventilator. So transportation challenges, infrastructure challenges, all of these make it very difficult to provide our patients the care that they do need. It also makes it difficult for the patients also to access the care that they do need. Another challenge is about shortages in workforce, which you've seen has been playing over and over. Just a few seconds, please. The shortages in the workforce, you've seen young doctors that are unemployed around the community. We've seen the high turnover rates for doctors working in rural areas, burnout among these doctors in rural areas. And when they engage and encounter burnout and then they leave the system, now there's further work strain on the system also. And that leads to inconsistent care, leading to overburdened facilities. And it makes healthcare for some people an unattractive discipline. And when we look at their disparities, the healthcare disparities, especially within the rural communities, often experiencing higher prevalence rates of certain diseases due to socioeconomic factors, limited access to preventative care, health education, the long waiting time. These disparities, they underscore the urgent need for an extent, innovative solutions to improve healthcare outcomes in this region. And that's what it challenges me as a rural GP or as a rural doctor working in one of the local clinics here in KwaZulu Natal. And that's where telehealth and telemedicine has, in my opinion, revolutionized rural healthcare, especially post-COVID, because what it has done, it has, one, expanded the access of rural doctors to specialists, and also reducing the need for travel of some patients. I remember when I used to work in one of the rural hospitals, I think it was in Kokstad, and I think it's almost about a 3-hour drive from there to our referral hospital, which was Edendale Hospital. And at the time, we only had 3 ambulances. One was for maternity care, one was for, and the other 2 one was for running around the community, and one was for emergency care. Now, if it happened that there was an ectopic that went down, one ambulance is gone. If it happened that there was an appendicitis going down, ambulance is gone. And you're stuck, and you're not able to have to get the healthcare that your patient really requires in those places. And for me, this has been a big boost in my practice, both in the public sector and also in the private sector. Engaging with specialists through the use of video conferencing, it has really enabled better management of many of my complex conditions, especially when it has to do with dermatology. And at the moment, for many of the rural hospitals in this part of Pietermaritzburg, there is a dermatology WhatsApp group where the specialists at Edendale and the registrars at Edendale formed a WhatsApp group where every day you are seeing a case in your facility, the case is put in the group there, the consultant responds to that case there, everybody learns, and it happens almost in real time. I think the longest waiting time we get in response from the specialist during working hours might be about maybe 20 minutes. And what happens is that there's ongoing health education. The doctors become more confident because they've learned from other people's cases on how to manage these patients. Now, you also reduce these patients being referred unnecessarily to the specialist, except maybe they need to get biopsies and stuff done. For me, in my practice, one of the practical uses I've used it, especially with the use of WhatsApp, has been one, patient education, using my WhatsApp status. I know some people might say, but I don't want patients having access to my personal WhatsApp, which is understandable. Then you can also get another secondary line, which you can use for patient education, because patients are online, actively online, and they want to hear from a credible source. There are a lot of quacks out there who are giving health education, and it'd be nice that if their local doctors in their clinic or local doctor in their community is the one providing this education part of it, also when using it for following up of patients. One of the other uses I've used is managing patients who are maybe they're starting on insulin. Now you want to see if their medication is working. You want to give an appointment to come back. Many of them only manage to get transferred money to come to the healthcare facility when they've gotten their pension, and you're asking for a follow-up date, and they might not have the opportunity. That you can use the use of WhatsApp to follow up on them. They can take pictures on their glucometer. You can advise them on how to increase the dosage if need be, reminding them for their contraceptive injection, or even giving brief consultations to patients. So telehealth is one of just one of the tools that I think has been untapped yet, but in the coming months and coming years, I see it being an indispensable tool for rural healthcare workers and rural healthcare practitioners towards providing better care for their patients in those communities. One of the other things I've seen that we've been quite helpful has been the mobile health clinics. And the NGO Think for the past few years has been offering in the area where I have been mobile X-ray services, where on certain days during the week, the patient, they come into the facilities to offer X-ray services. Not just only healthcare services. I mean, there are some unserved areas. I'm going to use one of the areas where I work, which is called Hopewell. Before we opened our practice in Hopewell, there was no clinic in Hopewell. Hopewell has a growing large community, and all have to take transport from there all the way down to Pietermaritzburg, even just for contraceptive services, chronic medication. But I see that over in the past few years, mobile clinics have started popping up there to provide medication for their chronic medication, such as their ARVs, their TB medication, even their non-communicable chronic disease are being managed by mobile clinics. And that's really helpful by taking healthcare to the community and not waiting for them to come to us. One of the biggest challenges I also experienced has to do with health information systems. And before I hit that, I've on the screen here, I've showed four services here. One of them has been one of the EM Guardians has moved on to offering a scripting service where, well, now this is not for the rural healthcare, but it also helps in my community, where I can renew scripts for my patients electronically just from the comfort of my phone. And when this script is sent, they are legally accepted scripts. The patient only has to click a link, and almost all the local pharmacies are populated, and the email addresses are there. The script goes to the pharmacy. Even if it's a repeat script, they've automated in such a way that patients can receive repeat scripts every month, automated, without you having to remember that. And that's really helped my rural practice a lot. And when I see the advances of this app called Vula, which I'm sure many of you are using to discuss patients with your tertiary center, I was reading one of your news letters, and they said they had done over 100,000 eye care referrals. Now, there probably have been other referrals for the departments that have been much more than that. But what this has helped is that it's a secure way where you can discuss patients with your referring facility. It's kind of secure. You don't have to save even your patient information on WhatsApp. And it's easy because when that doctor you've discussed with has gone off shift, he can even transfer that information to the next person on call, and the person doesn't have to contact you forwarding WhatsApp messages. So VULA is one of those indispensable resource for me as a rural care physician who discusses patients with my referring facility. The CCMDD, which has to do with chronic medication, which I feel has been an underutilized and untapped resource that the government has made available, especially for stable patients who are on chronic medications, who do not need to come every month to join the queue in the clinic, adding to the longer waiting time for someone whose blood pressure is already controlled, someone whose diabetes is already controlled. I think the 6-monthly visit would be ideal. And that's how we need to get many of the healthcare practitioners to become more tech savvy, which from your phone, you can renew your patients' chronic medications, so they don't have to join the queue except there's an acute problem. Another resource that I use very often is called UpToDate. And UpToDate is a comprehensive healthcare resource. It's also a very expensive healthcare resource. But one thing I had noticed from UpToDate is that they do have a program where if you are a rural doctor or you work in a rural facility, you can get access to UpToDate for free. I have used UpToDate for free since 2017 up until now. I haven't paid for UpToDate because I'm working in a rural area. And I feel that if you're interested in wanting to know how that is, well, you can reach out to me and I'll let you know how to go about that process. Because every year they donate multiple access for doctors working in a rural area. And I feel that it's an invaluable resource that can be used. But yes, the implementation of electronic healthcare records and improved data sharing, it can really assist in managing our patients in rural areas. And these systems, they also improve patient tracking. And even if you're coordinating care of patients, we also need some form of electronic health system or health records, because this will also assist in leading to better healthcare outcomes. The organization called Health System Trust has been quite instrumental in implementing electronic healthcare records across many rural healthcare facilities in South Africa. So, to some of the advances, Now, the delivery models that exist, I feel that we can improve on these delivery models that exist. But some of us are not even aware of the existing delivery models beyond the patient just coming into the facility. For example, the community healthcare workers, they play a very crucial role in bridging that gap between we healthcare providers and the rural community. In India, they have this program called Operation ASHA. And in that program, they will use extensively community healthcare workers to deliver TB treatment. And that helps in improving treatment adherence for the community. And when you're combining community involvement with technology, it comes out with impressive results. Now, in the integrated care model, when we talk about the coordinated care approaches, such as this integrated care model, these models are also essential in providing comprehensive healthcare. I mean, they ensure that our patients receive their holistic healthcare. And when I had a chance as part of AfriOne to observe healthcare delivery service in Uganda a few years ago, there was a program called the Mama Toto program in Uganda. And what they did was that they extensively integrated health education, community mobilization, service delivery, and technology, and we were able to use it to improve the outcomes in their maternal and their child outcomes. So I feel that we can use our existing integrated healthcare models and make it work better, more efficient, to be able to deliver better outcomes for our community. Now, obviously, most of us are working in the public sphere. I've been very privileged to work in both the public and the private sector. But public and private care partnerships, they are quite vital in enhancing rural healthcare, because sometimes some of these collaborations between the public and the private outcomes entities, they lead to improved resource allocations and service delivery. A few years ago, I think it was in 2017, I had a chance of being in Australia, and I had to observe the Rural Healthcare Initiative in Australia. And that was, in my opinion, a testament of how the positive impact of such partnerships can improve healthcare outcomes. But obviously, the biggest problem we always face is always the issue of funding. Funding. But I feel that beyond just funding, there's also a need for government policies that support rural healthcare. And those policies are very crucial. I know there are existing policies. There are a lot of existing policies for rural healthcare. The challenge has always been an implementation challenge. One of the most controversial policies is the NHI program, which on principle aims to provide equitable healthcare access for all citizens, especially even those in the rural healthcare. What we are worried about is about the issue of implementation, which we are hopeful that, one, the implementation will be good and will not even take us backwards as in terms of our healthcare outcomes. But sustainable funding is quite essential for the success of our rural healthcare projects. Yes, presence of grants and fundings, both from government and also from non-governmental organizations, they also help to support implementation and the maintenance of these programs. Unfortunately, due to funding issues, the picture I shared before about the mobile X-ray services that we used to enjoy, seems to have cut down, all due to funding issues. But organizations such as the Health Systems Trust, the Think, and similar NGOs, they are very, very important, and they play a very significant role in securing and managing these funds so that our healthcare system doesn't go under. Now, there have been a few case studies, to look for them, where these have worked. And just looking for where I wrote them down properly. Yeah, a few case studies where there have been some success stories in the advancement of rural healthcare delivery in many places. I know you see the one about USA, and obviously USA might not be seen as a rural area, but there are quite rural areas in the USA, especially in the Middle Belt, or also called the Rusty Belt area. In the part of USA called New Mexico, which it's not as beautiful and big as the big cities that we know, as the New Yorks and the Californians. But in New Mexico, the Project Echo was where they had used the telementoring program, using video calls to connect rural healthcare providers and specialists, especially specialists in the academic centers. And the aim of this was to consistently aim to improve the capacity of rural healthcare providers to treat complex conditions. And I feel that we are in a space where that can be very helpful, because we rarely see specialists in rural areas. In fact, I don't see any specialists in rural areas. They're all in the urban cities or in the tertiary hospitals. But they can help a lot using telehealth to build capacity among young doctors, among rural doctors, so that we don't feel left out alone in our rural practice and feel that our skills are not improved, we're getting redundant. So that project was a success story which helped in increasing and improving capacity for healthcare workers. The Operation Asha in India was another success story, and that one, what they did, that they were able to dramatically improve TB adherence. So what they did was that many of the underserved areas in India and some parts of Cambodia were affected by TB. And what they did, that they utilized a network of community healthcare workers. They used biometric technology, and then they were able to use that to ensure that the patients were able to complete their TB treatment. And that was for me a big success story because one, it improved the TB adherence rates and also reduced their default rates. And when that happens, it demonstrates the effectiveness of combining community health work with technology. So technology can help to track and ensure treatment adherence, but also we also need people in the rural areas, which are quite crucial to be involved in visiting these patients. Of the VULA mobile project, sorry, I missed the word I, improve access to specialists. It started a few years ago. I think the company is in Cape Town, and it has improved over the past few years. And in my opinion, it's one of the success stories for rural doctors having access to specialists and getting healthcare. One of the recent examples I had was a patient that I was struggling to deal with. And I know that the waiting time or the waiting time for the patient for the plastic surgery clinic, at least for here, I know it's almost 8 months waiting time to get an outpatient appointment in the plastic surgery clinic. But using VULA, the doctor was able to talk me through what he needed me to do. He asked me to send photos, and he sent a video and told what he needed me to do. He asked me to ask someone to take a video while I was doing it and send the video back to him using the VULA app. Now, yes, does he have his challenges? Yes, sometimes it can be slow. Sometimes we might have data problems in our area. But is it a step in the right direction? I think it is. It is a step in trying to build capacity and also improve healthcare outcomes for people in the rural area. So, as we come towards the end of this presentation, here are a few things I've written here that I feel that one of the lessons I've learned so far, and I'm just going to read them out. It says, leveraging technology and telehealth can extend specialist care to remote care areas. And that's quite true. It has really helped me personally in my practice, both in the public sector as a doctor in the local clinic, or even in my private practice, where I have to speak with our specialists also, it has helped me. But I see that I cannot get it done alone without the involvement of community and the use of local healthcare workers, because their presence helps for sustainability and also helps for us to check on how we can improve the services that we provide. Yes, funding is always a challenge, and sometimes there's a benefit in public-private partnerships because this helps to build robust resources that can help to improve service delivery. When I used to work as a rural doctor before I went into residency, I was quite despondent in my first year there. Yes, I had chosen to work in a rural hospital. Before then, I worked in a tertiary hospital, King Edward Hospital, and I was quite concerned that why were the patients, especially those with breast cancer, why were they all coming quite late when the cancer had gone far? What was going on? And when I spoke to the patient, they're like, oh, I was waiting for the sister to refer me. I'm like, but didn't you see when things were getting worse? What happened? Why this delay? And that's what prompted me to desire to go to work in a rural area. And I went to work in Coxside. Yes, Coxside might not be considered a rural area, but for someone who had worked most of his life in Durban, for me, Coxside was a rural area. I was there with a young family. My wife had just finished her PhD, and we had to, we're thinking of the schools that we left our kids in Durban. We had to explore homeschooling, and it was a very rewarding experience for me. Obviously, homeschooling is not for anybody, but it was a rewarding experience for me. Sometimes we worried that our skills were stale, and sometimes, and when that happens, and that's where the context of continuing education comes in, because it helps to support rural healthcare providers in building our confidence, feeling that the value we're giving is good and up to date, and so that we can also improve patient outcomes in these areas. And also that's why partnering with, if you're watching this video and you have not partnered with RuDASA, I'm going to encourage you to partner with RuDASA and its key partners, because it exists as an existing resource for you as a rural healthcare worker to sustain and to thrive in your rural practice. At this point, I want to thank you so much for listening to me, and thank you for staying with me throughout this past few minutes. I'm going to pause here for questions and suggestions and yes, and your ideas. Thank you so much.
Hi, so has anybody got any comments or questions that they'd like to ask Dr. Ettang? I know that I want to know some of those, some of the telehealth links. If you could send those to me so I can send them out to the RuDASA members, that would be great. I mean, some of them I know, like the WONCA app, obviously, but you were talking about things that I'd not heard of. I don't know about whether the doctors, the rural doctors, have heard of them or not. But that would be very helpful.
I will provide. I have a like a resource pack for telehealth services available, and I'll prepare that available. Yes.
Thank you. That will be great.
Maybe a question.
Yes, sir.
So as a private practitioner offering advice on your WhatsApp, etc., how do you get funded from your patients? How do they pay you for your service?
Okay, thank you so much for that. So there are two. I have currently three models that I use. I have the freemium model, which is free, which is for those who have access to me and have my number. Yes, they're able to get some information on my status when I do. If they follow my WhatsApp status, they can get that service. Now, obviously, it gets very busy when everybody's asking a question, and you also have to do your day job and also respond to the question. So, I have a call it a monthly. Okay, it's a paid monthly package where people pay a small monthly package where they have access to me, and I'm able to respond to their questions or concerns within a time frame of within 1 hour during working hours. Yes, and then for the online consultations, it's very easy these days. There are many platforms that offer links where patients can make secure payments online, either using their bank card, such as there's a Yoko app or the Ikoka app. And these are recognized companies, and they are secure. So people do not, your card details do not get into the wrong hands. Yes, there's a place for the EFTs for those who want to do that. But also there's a community that do not have funds online and they want to pay by cash. So that's a very difficult model to deal with, especially when they're not close to you. If they are my existing patients that I've seen before in my practice, obviously it's very easy. We can always arrange for when the payment will be made if they are my existing patient. But if it's someone I've never met before, I've never integrated with, it's kind of a bit of a tricky one. But as I mentioned, there are apps such as the Yoko app, the Ikoka app, which also provide, if you're using an Android phone, it can actually turn your existing Android phone into a POS machine also.
Mm-hmm. Okay. So the technology helps your payment system as well, eh?
Absolutely.
I was in a talk in, I'm just trying to think where it was. I think I was in Rwanda, and someone was talking from India about developing home-based care operatives who connected through their apps to the clinician. And so within a town, he sent these people out, and they would provide a home-based care service with consultation. And he was able to direct and even prescribe within the Indian context. And through these non-medical people who are home-based care workers, he was able to deliver care to patients in their home. So it's an interesting thought, isn't it? That one could extend the works of the home-based care workers, which you mentioned, if you could empower them with a clinician behind them to give them some more backup to their management and treatment of patients. Obviously, within a government system, it's not a big problem because a government system, you can have the link and it just happens. But when you go into the private system, obviously there's issues of payment, there's issues of liability as to how you manage those systems. Have you had problems with liability?
Well, I do. I haven't had a problem yet. I do have indemnity cover for my practice. I started using it in my MPS since before becoming a registrar, and when I got into private practice, most of the private hospitals required that you had to have indemnity cover before you work in those places, and I felt it was quite helpful for me also to cover myself. But just to add to what you mentioned about that, in one of the places, especially in Hopewell, which obviously I'm not there as often, but as I like to be because I'm mostly in Richmond. But in my room there, we also provide a computer. There is a nurse that sits in the room there, and when a patient comes, just sometimes it might not be a full consultation, but I'm able to also give telehealth care in the room there. So if they don't have access to data, they come down to the room there. There's always somebody there during the daytime, and then they can connect with me from where I am. And obviously, if it's about medication, if it's about something that requires me examining the patient, it gets tricky when you have to do examinations. Yes, there are apps that you can check your oxygen saturation using the camera of your phone. There are apps that can check your blood pressure using the camera on your phone, or if you had a smartwatch to check your blood pressure. I dropped one of my iPhones and my Apple Watch there, so they can also check my oxygen saturation for the patient when they're in the room there. So there are some of these techniques available. Yes, it all comes to one being interested in exploring that to support your practice as a rural practitioner, and also investing in those technologies.
That's interesting. And have you had any experience of point of care ultrasound with the modern small ultrasound devices that can be fitted to cell phones?
I wish I could have shown you. I actually do have one of those. So I use them when I'm going for home visits. So I connect them through the USB to my tablet or to my phone, and we're able to do quick ultrasounds there at the home when I do my home visits for patient. I have that, and I have a small portable one. So the challenge was that the small portable one that I initially got, while it is cheap, okay, I won't call it cheap to buy, but while it seemed like a low barrier to entry investment, the challenge was that you had to pay a licensing fee every year for the app, which over time, and it was in euros at that time, became a little bit expensive. So I I balanced that with my small portable ultrasound that looks like my laptop, my small probe, which I use that as a point of care ultrasound when I go for house calls and home visits, which are other services that I do offer.
Thank you.
Thanks.
Does anybody else have a comment or question for Dr. Ettang? Okay, so if not, then I'm just going to launch the poll, hopefully. So the poll is what you click on, and we use this for your CPD points. So if you can just do I think there's 4 questions that are there. Can you see the poll? I get a different copy to what you get.
Yes, you can see it.
Okay, great. Okay, well, thank you very much, Dr. Ettang. I'm going to check that this has gone onto YouTube. It looks like it has. And then I will send out a notice to everybody saying that they can, those that missed can check the presentation on YouTube. And it will be great to have that resource pack that you've got.
I will package it and send it to you.